listening to the Pharmacy Podcast Network.
3, 2, 1.
Adverse drug reactions, or ADRs, are a serious issue in healthcare today. The pharmacist is the last line of defense to help prevent ADRs. A rising role of the pharmacist is the specialist who focuses on our children. Pediatric pharmacy ensures safe and effective drug use and optimal medication therapy outcomes in children up to 18 years of age. Currently, there are more than 1,450 board-certified pediatric pharmacy specialists, known as BPS. If you're interested in this expanding field of pharmacy, this podcast is for you. All right, everyone, let's give it up for our host.
Hi, everybody. How are you? This is Jenna Quinn from the Pharmacy Podcast Network. I'm excited to introduce myself and my new co-host, Justin Cole. We are doing the Pediatrics in Review. So this is Jenna Quinn, and Justin, I'll let you give yourself an introduction.
Yeah, excited to be with you again today, Jenna. I'm excited for our topic today and our guests. I think as we continue to roll on the podcast, we continue to find great topics that are pertinent to today's pharmacists and other healthcare providers in pediatrics. So looking forward to today. Yeah,
so today's topic is on cow's milk allergy, which I know a lot of parents experience, especially when they're in the early stages of parenthood. When parenthood is already super hard, you have a complete shock to your system when you start parenting, and you're already in this whirlwind, and then add on this allergy. It can be really truly difficult for families to navigate. So we're really excited to have such experts here. We are today talking to Dr. Jennifer Lightdale and Dr. Karen Switkowski. And so I will first let Jennifer introduce herself.
Sure. So my name is Jennifer Lightdale, and I am a pediatric gastroenterologist. I am the Associate Chief of Gastroenterology, Hepatology, and Nutrition at Boston Children's Hospital. And a long time ago, perhaps because at that point I was a new parent myself, I actually felt badly for all those parents who were really sort of encountering this diagnosis, which is more common than people realize. And I think it's been a personal mission to both educate the parents, educate, frankly, my colleagues, and yes, pharmacists and anybody else involved in the healthcare system, because I think it is an under-recognized condition. And then, yes, with Karen Switkowski, I'm also engaged in research to try to understand it more in ways that maybe can change the paradigm a bit. So I'll hand it to Karen to introduce herself.
Sure. Hi there. So I'm Karen Switkowski. I'm an epidemiologist and research scientist at the Harvard Pilgrim Healthcare Institute and Harvard Medical School. I work on a cohort study of mother-child pairs, where we do a lot of research, including research in food allergy. And most of my research, in addition to food allergy, is just kind of generally focused on child feeding and nutrition. So do a little bit in pregnancy nutrition. And also the parent of a child with food allergies, not milk allergies specifically, but other food allergies. So definitely I'll also have that personal experience with how difficult this can be.
Wow. I love that you bring so many different perspectives to this. So excited to dive right in. So if for context, maybe we could just simply start by providing some background information on reactions to cow's milk in children. How common is a true allergy, and what are some of the common signs and symptoms that you typically see? So, Jennifer, maybe I could ask you to start with answering that question.
Sure. So I think when you think about adverse reactions to cow's milk, it actually can be either an adverse reaction to lactose, so that's lactose intolerance, or it can be allergy. And both are actually really common, although they're common at different stages of life. So lactose intolerance is going to affect people much later in life, while allergy to the proteins in cow's milk is actually one of the most common food allergies in childhood, where we think about up to 2% of preschool children will actually have antibody to the cow's milk itself. So those are IgE allergies, and a lot of others have non-IgE reactions going on. And then if you ask me, well, what are common signs and symptoms, like you did, Justin, I would say true IgE allergy, so to speak, is going to be hives and maybe even anaphylaxis, sort of what you think of with an allergy. But either type of allergy, either IgE or the non-IgE, can involve stomach aches, irregular bowel movements, sort of non-specific GI symptoms, which is why as a pediatric gastroenterologist, it's very common for me to be thinking about this.
Awesome. Thank you so much. Okay, so my next question, and I'll ask Karen, what is the etiology behind the cow's milk reaction in children, and how does that differ from lactose intolerance? I know Jen kind of touched on this.
Yeah, so as Jennifer said, cow's milk allergy is a reaction of the immune system that is specific to a protein in the milk. Typically, this is casein or whey that the child's reacting to. And in contrast to an allergy, which again is a reaction to a protein, a lactose intolerance results from the body's inability to break down lactose, which is a type of sugar. So we have a reaction to a protein with allergy versus reaction to a sugar or a carbohydrate with lactose intolerance. So when someone's not producing the lactase enzyme, their body will not be able to break down and absorb lactose, which will then lead to these various GI symptoms associated with lactose intolerance. Whereas an allergy, again, is really this reaction that's mediated by the immune system. So typically with looking at babies and young children, lactose intolerance is generally not an issue. There are a few different types of lactose intolerance that can impact babies, but these tend to be either extremely rare or temporary. And generally, if there's a reaction to milk or milk products in young children, then we would suspect a cow's milk allergy as opposed to lactose intolerance, which typically doesn't manifest until 5 years of age or older, even in populations where it tends to be pretty common.
That's great. Thanks for the background information. So I'd love to know if you guys could kind of walk us through a timeline or brief history of previous recommendations related to the timing of cow's milk introduction to infants. Where have we been over the past decade or longer in terms of when we would suggest parents introduce cow's milk into the diet?
Yeah, so the guidelines for prevention of food allergy in general have changed a lot in the past 20 years. It's actually a very interesting history. So in the early 2000s, most of the guidelines were recommending avoiding early life exposure to potential food allergens altogether, including cow's milk. So this included restriction of the mom's diet during pregnancy and breastfeeding, as well as delayed introduction of commonly allergenic foods like peanuts, eggs, seafood. Typically, it was recommended that these not be introduced until 2 years of age or later. Although cow's milk is interesting because it's sort of different in that milk and milk-based formulas have always been introduced much earlier than that. So we saw that rates of food allergy kept increasing, and it was able to accumulate more evidence since that time, which has pretty consistently confirmed that actually earlier introduction of these common food allergens appears to be protective against the development of food allergy. So then in 2008, the guidelines were revised to recommend that the common allergens be introduced along with other complementary foods at around 6 months of age, and even earlier for infants who are determined by a physician to be at high risk of food allergy. So those tend to be, the infants with a family history, those with moderate to severe eczema, or with other known food allergies. And then just a general point, the introduction of any complementary foods is not really recommended before 4 months, just because the gut barrier is not quite mature enough to handle those food molecules, including allergens. But we know that cow's milk protein is often introduced much earlier than that, even within the first day or two of life, in the form of cow's milk-based infant formulas. So we were really interested in what the implications of this might be. And we're also interested in focusing on cow's milk just because a lot of this research suggesting that earlier introduction seems to be protective has focused specifically on peanut and sometimes egg, but we don't really know as much about whether these findings extend to other food allergens.
Are you guys for or against using, there's this is because I have an 18-month-old too, so I'm up on, the different sorts of food formulations they have out there. But are you guys for or against? You know, those spoonful, like those little puffs that literally have like every single allergen. At 4 months, I gave them to my 18-month-old. Is that something that you're encouraging parents to do, or what's your take on that?
So I will tell you, I think it's been an awesome marketing concept that, hey, let's give you this simple little puff that sort of does it all. I think the basic principle of exposure is appropriate between 4 to 6 months of age can be accomplished without buying the puff. So, you know, if you want to buy the puff and make it easy on yourself, and frankly, you can afford the puffs, that's great. If it's really a matter of just exposing the baby, which ideally helps avoid healthcare disparities, that's great too. So I think the key is the principle and what works for you as a parent. So.
Yeah, as a mom of 3, there was no way I was getting like organic ways that I was going to make baby food for this 3rd child. I'm like, here's a puff.
Which is, again, totally appropriate. I just think we want the guidelines right now to be able to work, you know, regardless of where you live and how easy it is. But yeah, I think the bottom line is there's a market out there for getting these guidelines right, and you're seeing it in action right now as a lot of companies are jumping in.
So if I could just throw a question in there, Jennifer, I think you hit on something really important, and that is thinking about access and even the social determinants of health related to the introduction of various allergens. So maybe could you expand on that a little bit more about why you feel impassioned that those guidelines need to include a consideration for those social determinants?
Well, I think, the bottom line is, I think what we're seeing across the world in a global way has been this increase in allergy and allergic conditions, and that is probably the effects of being in a developing country, but also, frankly, globally. You're realizing the climate change is having an impact. Everything's starting to impact humans, and our immune systems are reacting, and you're seeing more allergy going on. Definitely, people in developing countries are going to be suffering probably more from those effects than others. And again, we want to get these guidelines right. We want to understand the public health implications, and we want to be putting out recommendations that are going to work regardless of whether you live, in a high affluent area, a zip code, or you live in an area that you have a food desert, can't get to certain foods. So I think we need to talk about principles, et cetera, if that helps, Justin. But
yeah, that's great. Thank you.
What do the role of genetics play into milk protein allergies?
Yeah, so I mean, again, I think we're talking about the environment that allergy is starting to increase. But the other thing we know is that there's probably a hereditary predisposition to allergy. So while genetics may play a role, it's probably more complex than that, and we definitely don't fully understand it. What we do know is there are families who have immune systems that do seem to easily react to the world and to things. So there are hereditary risk factors in that if your parents or your siblings have allergies to food or the environment or eczema, asthma, seasonal allergies, all of these conditions means they are themselves atopic, and an atopic family history is definitely a risk factor for the child themselves to develop atopy, with cow's milk allergy being one of the first signs of that.
So you guys have given us great background information here. I want to dive a little bit more into your specific work in this space and your collaborations together. So to maybe tell us a bit more about that and how some of the things that you are studying may help us to really define the most appropriate timing of cow's milk introduction in infants. So I'll give both of you an opportunity to talk about your own work in this space.
Sure. So I can get started with this. We know that with cow's milk, it does seem that early exposure seems to be important for prevention. But, as we've mentioned, milk allergy is sort of this interesting case where it's often the first food allergen introduced via these milk-based infant formulas. And also allergy tends to show up very early, cow's milk allergy specifically, suggesting that, the risk of allergy might be impacted even by what's happening before the baby is born. So we were really interested in this. There's sort of various ongoing research in this area. But a lot of studies have shown that the importance of early and repeated exposure to cow's milk protein, this really seems to be the key here. So we did a study in Project Viva, which again is a cohort study of mother-child pairs, and we found that babies who were not introduced to cow's milk protein until 6 months of age or later had a much higher risk of what we termed a cow's milk adverse reaction in early childhood than those that were introduced younger, so within 2 weeks after birth. So the other thing we were very interested in looking at here was this concept of transient exposure to cow's milk protein. So there's a little research suggesting that this is important. And what we're talking about here is exposure that's sort of brief and temporary, but doesn't get sustained. And sort of the classic example is the bottle of formula that babies get in the nursery or in the hospital, right after delivery. And then they go home and they're exclusively breastfed and they don't continue to get exposure to that cow's milk protein. And then the idea here is that, they become sensitized to the allergen, but then they don't go on to develop tolerance to that allergen if they don't continue to be exposed to it. So we had data on all of this, both whether the baby had received any formula in the delivery hospital, as well as the timing of their first introduction to cow's milk protein. And we consider this first exposure to either be a cow's milk-based formula or complementary food containing cow's milk if the baby was exclusively breastfed until the time of introducing complementary foods. So in our study, the babies who were given some formula right after birth and then went on to continue to receive some milk-based formula in the first 2 weeks of life had the lowest risk of developing cow's milk allergy of any other babies in our cohort. And then among the babies who didn't get any formula after birth, the best time to introduce cow's milk protein seemed to be sometime between 2 weeks and 6 months. Unfortunately, we just didn't have our data collected in a way that we could examine more specific exposure windows within that time interval. But definitely our work does seem to support the recommendations that cow's milk-based dairy products should be introduced along with other complementary foods and potentially allergenic foods, sometime between 4 and 6 months of age. But it also really highlights the significance of these formula supplements that are often given right after birth. And sometimes this is not avoidable, and certainly this is not an argument in any way against formula feeding in general. But really, I think the message here is that mothers who are intending to exclusively breastfed just might want to avoid that post-birth supplement if at all possible. Just because, we did see that sort of transient exposure seemed to increase the risk of having a later adverse reaction to cow's milk.
And if I can be reassuring, if they say, oh, your baby, and this did happen to me, my baby is now 22, but she was low in her blood sugar right in the delivery room. She was very small, and we gave some formula right away. That's okay. That avoided her needing other things. But it does mean that maybe it's appropriate then to continue to give her small exposures now moving forward. So, it's not terrible. It just recognize that exposure early on should be followed up with regular now exposures moving forward. So
can I ask, as a breastfeeding, I'm like one of those weirdos that I would breastfeed my child till 25 if they let me. So
you'd have to go to college with them. So
yeah, each kid is 2 years and then things get weird and I'm like, all right, mommy has to grow up. It's totally me. So, I 2 years with each my kid, 18, my last one, it's going to be super hard for me to stop. But a lot of moms experience, can you explain to me with breastfeeding, is that milk protein allergy still there? And do you have success when they restrict their diet? And do you recommend they restrict their diet? Because obviously this is all super hard on your mental health too. I think we should, address that topic as well. You're a new mom and now you have all these dietary restrictions. And so as a breastfeeding mother, I would love to know, how you guys counsel on that point.
Yeah. So I'm a pro-choice person. So whatever somebody wants to do, that's what I'm trying to support them with. And I certainly have moms who want to exclusively breastfeed or just, breastfeed. Sometimes they're supplementing too, but they want to be breastfeeding. And I want it to be a pleasant, wonderful thing that they want to do till their child's 25. So, so my goal is obviously not to stress them out with the diet. What we do know is maternal breast milk does reflect maternal diet. So, in America, where we have so much dairy protein in our diet, it will be expressed in your breast milk. And it may not look exactly like like straight cow's milk, but it's certainly, if you remove dairy proteins from your diet, you won't find those oligopeptide chains in the breast milk. So I think some babies are really reacting, and then we have to limit mom's diet in a way that the baby isn't reacting. And usually, again, it's sort of, I call it poetry in motion. It's very much a moving target. So often once we get things under control, you're able to reintroduce some degree, and sometimes it's baked, and some in the sense that you've changed the proteins a bit. So baked milk in good, sometimes it's just a small amount, so you can handle a little bit of milk in your coffee. But if you do milk in your coffee plus cheese plus yogurt plus ice cream, that's when the baby has a reaction. So you have to sort of figure that out together. And there are ways to do that. Again, ideally working with somebody, either a dietitian or a provider who can guide you through. But it is about how much can the baby tolerate, and then back to what our study is showing, still getting exposures. In the end, if we want the baby to get over the allergy, we don't want mom to fully exclude the protein if the baby can tolerate small amounts, because in the end, that's going to be best at helping the baby get over the allergy.
Yeah, by the time I figured out my daughter had an egg allergy, I had a whole freezer full of frozen breast milk with egg in it, and I was throwing that out. So we just did, small exposure mixed with the egg-free breast milk for a while, and it seemed to work out okay.
Hey, I know, that's gold right there.
Yeah, absolutely. So kind of moving back to a little bit about the actual reactions. I know we've talked about timing, and that's been a bulk of your work related to the importance of cow's milk allergy. We've talked a little bit about heredity. Are there any other factors that you have seen that increase the risk of cow's milk allergy specifically?
Well, Karen can probably talk to this better because she is just such an expert in Project Viva. But I think to the questions we were having before on trying to understand the milieu in which a parent is, Viva did let us control for parental history of atopy or allergy, what type of delivery the mom had, gestational age at delivery, even like household income and zip codes and things like that. And you saw some changes in our estimates that were slight, but these actually aren't strong confounders. So it really, I think, in the end, I think there really is going to be something to this better understanding of timing of exposure to foods that we want to have babies get, in those very early months of life, and how those are going to play out for preventing allergy, almost regardless of any other history you may have. I don't know, Karen, if you have other thoughts there.
Yeah, exactly. The only other thing I wanted to add was that we also did a little, basically what we call stratification. So we looked at these same associations between the timing of when the cow's milk protein was introduced and the adverse reactions within specific groups that were defined by different characteristics. So one of the ones we looked at was babies who had ever been breastfed at all, so either partially or fully breastfed, versus those who had only been fed formula since birth. And we saw the same associations there with timing and then adverse reactions. And then we also looked at those who had a parental history of atopic conditions, so either the mom or the dad had any history of that, versus those who didn't report any family history of atopy. And again, we really saw pretty much exactly the same associations. So that sort of increased our confidence that, this was really about the timing and not sort of associations of that timing with other factors that could be explaining that relationship.
Great. Thank you so much. What are your guys' takes on using, I feel like the word microbiome is super popular right now. I don't know, as a GI doc, I don't know if you think it's being overused or you really have the buy-in, but what is, does the gut microbiome play a role in preventing or treating cow's milk allergies? And if so, do you recommend pro and prebiotics to your patients?
Yeah, so first off, everybody's talking now about microbiome, which is kind of cool. Of course, it's all about the gut. And of course, actually 90% of your immune system is in the gut. So, it's really, it's patrolling the gut, looking for what it should be reacting to and what it shouldn't be. And we know it's interacting with the microbiota, all the different types of microbes that live in your gut. So I think there is interest in trying to figure out what could we do and how can we really promote a healthy microbiome that basically helps either prevent or even treat a food allergy. I don't think we're quite there yet. That's the problem. So we're just in the early days of understanding it. It's great that there's all this public awareness. It does make it tricky to give direct advice, but there's certainly interest in, can we, promote the microbiome with what are called prebiotics. So really making sure that that we enhance anything the baby's getting in terms of being healthy. By the way, breast milk is filled with awesome prebiotics, in particular GOS. And a few others like that are really quite good for nourishing the microbiome. And then there are probiotics, of course, that are, if you go to any pharmacy these days and any supermarket, really, you'll find the probiotic aisle. There's so many things you can be looking at. I think the problem there is we're just in the early days of understanding it. Having said that, do I personally? Yes, I've become convinced at some of the probiotic evidence, and I do talk about what I know about a few of the specific probiotics. Jenna, as you know, probiotics are not considered a food and they're not considered a drug, so they are not FDA regulated in any way. So it's a bit of a Wild West, but there is, I think you're seeing emerging evidence for certain strains that are helpful, and there are probably many others out there. We're just at the beginning of understanding it. So.
Yeah, Jennifer, you bring up a theme that I feel like just keeps coming up in our podcast. Jenna and I talked about CBD supplements that are unlicensed, and it's the wild, wild west there too, right? So anytime you get outside of the auspices of the FDA and really any requirement for verifying what is actually in the product, it's hard to know exactly what you're getting. So I'm glad you've just brought that back to the podcast and our listeners for us. So I want to turn a little bit practical for other pediatric healthcare providers that may not be a specialist like yourself in the gut, but may encounter families that there are concerning signs or symptoms, or maybe they've been diagnosed with cow's milk allergy. So let me start with asking the question: how can pediatric providers of care, including pharmacists, help to identify cow's milk allergy in children? What are those telltale symptoms where we should start thinking about, oh, you need to seek some medical care, some additional diagnostics to look into this?
Yeah, so I think the classic is the baby that seems uncomfortable. So they may be fussy, but then you want to put that fussiness together with other things going on, particularly other signs of atopy in the baby. So a baby with perhaps eczema or bad cradle cap or diarrheal stools or even constipation, very irregular stools, that suggests something's going on inside the gut that you can't see. And then frankly, you need to be looking for poor growth. So I think if the baby is skinny or they're not growing well and they seem like they have signs of atopy and they seem uncomfortable, that's number one thing that should be on everyone's mind is cow's milk allergy. And it can be a great relief to identify it. So I think what pediatric providers need to do is educate themselves, but then also turn around and educate families. And we started with this, but really differentiating between lactose intolerance and cow's milk protein issues is so critical, because people will say, well, I switched to lactose-free milk. I have, and that actually will not solve the problem of the allergy. So I think really being helpful at educating, explaining, and then reassuring, we're going to figure this out. It does usually resolve. And it's, and at the same time, it's telling you something about that baby's immune system. So maybe even anticipatory guidance of, well, okay, you're in a family with lots of people with seasonal allergies. This could be an early sign that down the line you're going to suffer that way. So again, not hitting them with that. Hit them with, it's poetry in motion. We just got to get you through it. So,
Awesome. What are some common misconceptions you see with cow's milk? I think you kind of just nailed it with like the lactose intolerance misconception. Is there anything else that we should be aware of as providers that's like common, misguidance, for lack of a better word?
Yeah, I mean, I think a big one is that, most kids outgrow a cow's milk allergy. It's usually not something that they have forever. You often see it with young children, and then they will eventually develop that tolerance to cow's milk. Another one has to do with IgE, which is a little bit, it's kind of complicated because we know there are reactions to cow's milk and also, other food proteins that are mediated by IgE. And then there are also reactions that are an immune-mediated reaction. So something we, would kind of categorize as an allergy, but are not mediated specifically by IgE. And the IgE ones are easier to diagnose because you can do these skin prick testing, you can do blood tests and measure the IgE, and then, see if there's elevated levels to help to diagnose that allergy. But the non-IgE mediated allergies are very difficult to diagnose. Typically, it's done with an oral food challenge, which is just kind of not a good experience often, I think, for the patients. And they just aren't, that's not often done as a diagnostic tool. So those can be a little harder to figure out, but it doesn't mean that if there is no evidence of an IgE-mediated allergy, that the child doesn't still have a cow's milk allergy or a different type of food allergy, if that's what you're concerned about. So I don't have a good answer to that because, again, it's those are harder to diagnose. We tried to get at this a little bit by looking at parental report of an allergy as opposed to just IgE evidence, which is what's done in a lot of studies, because we really wanted to try to capture those additional allergies that didn't have the IgE involvement. But that's just another one to keep in mind, that those can still be allergies, even if there's no evidence of the IgE. And then, I know there's often concern that kids who don't drink milk are going to have, poor growth, issues with not having strong bones, just concern about not consuming enough nutrients. And, while we know that nutrients like calcium and vitamin D do seem to be important for bone mineralization, these nutrients don't necessarily have to come from milk. There are other ways to get them in the diet.
What would you suggest as alternative sources for calcium?
Yeah, so kids who aren't having any dairy products at all can drink other plant-based milks. I also just wanted to be clear, I don't think I explicitly said this before, but babies under 1 should not be drinking cow's milk as a substitute for breast milk or formula. They can have other cow's milk-based products like, yogurt and cheese once they start having complementary foods, but really the primary source of liquid milk should be breast milk or formula till the age of 1. And then after that, they could start drinking like a plant-based milk. Only fortified soy milks are sort of officially recommended as a nutritionally comparable alternative to cow's milk, because these are really formulated to have similar amounts of the major nutrients. So protein, calcium, vitamin A, vitamin D, the ones that kids are commonly getting from cow's milk. But anyway, just to wrap that up, calcium certainly can be obtained from other foods, and vitamin D is the other one. Cow's milk is one of the few dietary sources of vitamin D, but there's really like nothing magical about getting it from milk. Like milk does not naturally contain vitamin D. Both dairy and soy milks are fortified with vitamin D, meaning that it's added during the processing. So kids who are drinking milk can get it, easily from that milk. But if they're not, then just like a basic vitamin D supplement will do the same thing. Since it's a fat-soluble nutrient, it's better absorbed if you have it with a dietary source of fat, but that certainly doesn't have to be from milk.
Yeah, those are great practical tips. I'd love to know, what are some other practical things that you tell parents related to managing cow's milk allergy in their child?
I think if you do have an IgE allergy that's significant, you may need an EpiPen. So I think, really recognizing allergy is complex. Certain types of allergy, you actually need to know an allergist, and you should be trained in how to administer an EpiPen. Luckily, most kids don't need medications. It's more a matter of trying to gradually do these exposures to allow them to develop what we call secondary tolerance. So they're having an immune trigger, and now we want the immune system to become more sophisticated and stop reacting. And so we're looking for that. As I said, these days we try not to exclude foods if we don't have to. It's more a matter of giving small amounts and perhaps modified ways. So really focusing on baked milk if that's what they can handle in the beginning. And then ideally in the second and third year of life, you're really able to increase to yogurts and cheese and ultimately not have to worry about it at all.
Our next question is, as a pediatric pharmacist, I see these parents in distress. I hate to use the word colicky because that's could mean anything, but you have this colicky baby, you've tried all these different things. Now, I would love to know the order of kind of how, if you think a child is having GI distress on your regular cow's milk protein formula, can you walk me through? And again, I'm assuming it's provider specific too. Do you first add an antacid, or do you first change the formula? When you say, okay, enough's enough, and completely change it to something like Nutramigen? I think as a peds pharmacist, we have to be good about obviously deferring to the specialist, but just kind of I always like to give the parents a couple steps ahead so they know what to anticipate. Usually the doctor will add this, or they'll change the formula to that. Sometimes knowing what's going to come, it's less of a shock to them. So I would love your art, as you said, of how you do that.
Sure. So fortunately, I have both art and there have been guidelines, and they are pretty consistent at this point. The other thing is they are really in the context of us recognizing that we were over-diagnosing GERD in infants. So many of the guidelines on how to manage this are in the context of a baby that is seeming to have GERD or dyspepsia. And then also, like I said, a big distinguisher is, are they growing or not? In the end, the most important thing is there's fussy babies, but there are fussy babies who aren't growing, and those babies have to get your attention. If you are either one, honestly, the right thing is dietary changes. And so if it's a breastfeeding baby, we do change mom's diet. The best evidence is for getting milk and eggs out of the diet, and I recommend to do that for 2 weeks. I used to at least very much focus on soy, because it felt like you took milk out and everybody went heavy soy in trying to compensate. It's interesting with almond milk and oat milk, and I feel like people are now, they're using these other plant-based milks, and it's not all soy, so you don't have as much of you might overcompensate with soy and actually run into issues that way. So having said that, milk and eggs, there's very good data for taking those out of the diet. I suggest that for 2 weeks. Usually things get much better. And now I'm trying to re-add things in slowly to understand how the baby's reacting. In a formula-fed baby, the change in the diet is really to go from intact milk protein to extensively hydrolyzed, not the partially hydrolyzed, like the gentle or the sensitive formulas, but really the extensively hydrolyzed formulas. And there are a number that really meet that criteria, including store brands now. So, it doesn't have to be a brand specific discussion at this point. It's really to recognize that we need to get the protein really hydrolyzed, go from, I say, 350 to 400 amino acids in a chain, which is sort of the very complex molecule that whey or casein is, down to you want to really be down at the 5 to 8, which is the extensively hydrolyzed, as opposed to the partially, which is more in the 30 to 50 range. So you're trying to really cut the protein down, and that makes an enormous difference. And it will keep the the more you cut the protein down, the less immunogenic it is. So the less it's triggering the immune system gets a chance to calm down, and now we can advance the diet once the baby is not having their immune system being triggered by their milk. So that's the formula fed baby, if that helps you as a pharmacist.
that does. And I think I just see so much Nutramigen, I don't know why that's what I jumped to right away. Again, this might be a very naive question since I'm not a dietitian. The extensively hydrolyzed formulas, are there any ones that, well, I know we talked about health equity, that are a reasonable price? Because I find that like a lot of times, these formulas can be so pricey that that's actually it's not feasible for
Yeah.
family.
Yeah. So the answer is that most are covered by WIC. So intriguingly, if you are using WIC, you're probably going to be okay, and that's across the country. The issue is, frankly, the people who are just out of the WIC range and yet not. So I think there has been an expansion in the variety of them out there, and I would encourage people to focus on that extensively hydrolyzed concept and not to be afraid to get a store brand version if that's the right thing. The key is it's really broken down as opposed to some of the name brands that come to mind, including, as you said, Nutramigen or Alimentum or some of the extensively hydrolyzed brands that are out there. But I wish I could say otherwise, but that does make a big difference. And frankly, if you address it right, then in the GERD guidelines, we have been able to decrease the need for the acid suppressing medicines. Those really should be after you've made the dietary changes, and you do need to make the dietary changes, right? And actually, Jenna, since yes, I can plug this to your pharmacy colleagues, and of course, people who I really count on. I think where families waste money is they try like 10 formulas before they go to the extensively hydrolyzed. If they went to the extensively hydrolyzed, they would they wouldn't have to go through all those formula changes, which I think is part of the mental health issue for families. They're going crazy trying to figure out what's good, the baby's going to calm down on. The other thing most of my colleagues will say is try to give it a good 2 weeks. I know if you can give it 72 hours, you're going to notice, oh my goodness, the baby is so much better. Like it really is. It's a pretty quick change. And that's probably the microbiome changing too. There's a little bit of evidence of that.
That's extremely helpful. And I think like in practice, I see a lot of pediatricians jump to adding like an acid blocker on, and the more evidence we have behind like a PPI and knowing that it's not a benign drug. So
that alters your microbiome too, right? So that we know that. So I think it's really, yes, we want to do those dietary changes first, and acid suppression really is only afterwards, once you've done that. So.
Yeah, Jennifer, as you've outlined, we have a pretty clear perspective on how to approach these cow's milk allergy in the youngest among us. However, I'm just curious, are there any new or promising treatments for cow's milk allergy on the horizon, or do you see this management approach continuing to kind of be the standard of care?
I think we don't. So the nice thing, as we've been saying, is allergy will go away. The immune system does mature. It does become better at realizing milk is good for you. It's intended as a food, it's not a foreign substance out to get you. So your immune system will stop reacting. I think where the really exciting evidence has been is in recognizing how we can have the right guidance for food introductions and perhaps for changing the world around us in terms of, climate change and understanding what our industrialized societies have done that might actually prevent it in the first place. The nice thing would be that you don't have to have families where, allergy sort of is there, and, we really can stop reacting to our world. So that's what my hope is.
Well, that's great. We appreciate both of you coming on to talk about your own work and what we can do as pediatric healthcare providers to educate ourselves, but also educate other people on these cow's milk reactions. But before we go, I just wanted to give you both a free platform to talk a bit more about, are there any other last messages regarding these cow's milk reactions that you would want to leave listeners and other pediatric healthcare providers with?
I'll say that as a gastroenterologist, I really encourage everyone to be fascinated by your immune system and really to respect that it's such an important piece of protecting you, but also something we maybe need to protect as we continue to be in our industrialized world, and really recognizing that we can figure it out and understand why there's been this rise in allergy and how we're going to stop that from happening. And I'm curious what Karen's going to say.
Yeah, so I just wanted to mention one thing that I feel very passionate about that's sort of related to this concept of food allergy, which is just that a parent's job really in this early feeding period, I think the most important thing is to just not create stress and anxiety around food. And that's, applies to all sorts of things, but it's very relevant and difficult in the situation of a food allergy because, you have this thing that, you want to teach your child that it can hurt them, it can make them sick, and they need to kind of be careful about avoiding it. Obviously, this is, relevant with an older child, but you don't want to be creating that fear and anxiety around food. And I certainly struggle with this myself as, with my own child with food allergies, but I think it's a delicate balance, but it's definitely something that's worth being aware of and just sort of thinking about how you're approaching that with your child, how you're explaining it, and just sort of that sense of fear and anxiety that you can be creating in the context of the allergy, which really, can sort of impact how they sort of relate to food and their relationship with food and eating in general. And we know that this is, this early toddlerhood, complementary feeding period is really a very sensitive period for sort of establishing sort of the relationship with food and, how kids are approaching and regulating their food intake. So just, it's certainly hard. I sympathize with it for sure, but just kind of something to be aware of and to think about parents, how they can sort of manage their own anxiety and not kind of project that to their child while still encouraging them to be aware and, protect their own health.
Thank you both. We really appreciate your time.
Thank you for having us. It was a pleasure.
That's all for today's episode. Thanks for listening, and remember to subscribe on Apple Podcasts and leave us a review.